All right, let's get right into it. Today we're diving into a really crucial aspect of maternal-fetal health. We are breaking down the exact environment your baby grows in.
Welcome to MediByte. We're your trusted healthcare professionals, and we're here to distill complex medical topics into clear, no-nonsense explainers.
To keep us perfectly on track today, here is our agenda. We'll hit 1. The role of amniotic fluid. 2. When there is too much. 3. When there is too little. 4. Spotting the signs. And finally, 5. Diagnosis and treatment.
Okay, kicking things off with Section 1, the role of amniotic fluid.
So at its core, amniotic fluid is the protective cushion completely surrounding the fetus, safely contained inside the membranes of the amniotic sac. You can think of it like the ultimate biological shock absorber. And much like the classic Goldilocks principle, we need these fluid levels to be just right. Not too much, not too little, but perfectly balanced for the baby to grow safely.
Let's move right into Section 2, when there is too much. In the clinical world, we call this polyhydramnios, or sometimes just hydramnios. Basically, it means there's an excessive amount of amniotic fluid for that specific length of the pregnancy. And this is a big deal because it physically overstretches the uterus, which can put a tremendous amount of pressure right up against the mother's diaphragm.
Now you might be wondering, what actually causes this? Well, we always investigate a variety of potential triggers. We're talking maternal diabetes, multiple births, fetal anemia, or even specific birth defects that might block the baby's esophagus or urinary tract. But honestly, here's the craziest part. Almost 50% of the time, despite all of our modern medical tech, the exact cause is a total mystery. It is completely unknown.
So why are we so vigilant about having too much fluid? Well, it can cause a pretty serious domino effect. That severe stretching can trigger preterm labor or cause the membranes to rupture way before labor even starts. Plus, all that extra swimming room might cause the baby to flip into an abnormal position, which often means a cesarean delivery is on the table. For the mother, it can cause severe breathing problems, and postpartum, the uterus might actually struggle to contract back down, leading to a major hemorrhage. Oh, and there's also the risk of umbilical cord prolapse, where the cord literally drops out before the baby.
To put this all into perspective, polyhydramnios risks are all about overstretching the environment and causing maternal breathing issues, whereas oligohydramnios risks, which we're about to cover, are all about restricted fetal growth and lung maturation issues.
Which brings us nicely to Section 3, when there is too little. We call this side of the coin oligohydramnios. This happens when there is simply too little fluid for the length of the pregnancy. And as you can probably guess, it presents a totally different but equally challenging set of hurdles for the developing fetus. The culprits here are pretty varied. It often stems from utero-placental insufficiency, meaning the placenta just isn't doing its job right, often because of maternal high blood pressure. It can also be triggered by the mother taking certain medications, like AC inhibitors for heart issues or everyday NSAIDs like ibuprofen. Other times it's caused by a rupture of membranes, a post-term pregnancy stretching past 42 weeks, or fetal birth defects, particularly involving the kidneys.
We take oligohydramnios incredibly seriously. See, an extreme lack of fluid, especially early on in the pregnancy, completely removes that protective cushion we talked about. Without it, you can see severe intrauterine growth restriction, or even limb and facial deformities because the baby is literally being compressed. It also severely delays lung maturation and can make it nearly impossible for the baby to tolerate the physical stress of labor itself.
All right, moving on to Section 4, spotting the signs.
Here's the really tricky part. There are usually zero direct symptoms for the mother. But the absolute biggest red flag we tell expectant parents to watch out for is decreased fetal movement. If your baby isn't moving around as much as they normally do, you need to get checked out. Now, in cases of excess fluid, a mother might also feel short of breath or start having painful contractions before her due date, simply because her uterus is stretched to the absolute limit.
Let's jump into Section 5, diagnosis and treatment.
So how do we actually tackle this in the clinic? The diagnostic journey usually follows 3 straightforward steps. First up, a doctor's evaluation to see if the size of the uterus actually matches the pregnancy timeline. Second, we do a targeted ultrasound to measure the exact fluid volume. And third, we run targeted tests, like blood work to check for diabetes or an amniocentesis to screen for genetic disorders.
Which naturally leads us to the biggest question on every anxious parent's mind. Once we know there's a fluid problem, how do we actually treat it?
Well, our treatment game plan is heavily focused on intense monitoring. We use regular ultrasounds to track growth and fluid levels alongside non-stress testing to keep a close watch on the baby's heart rate. We absolutely have to treat any underlying disorders, like getting maternal diabetes under control. And in very rare extreme cases of severe polyhydramnios, doctors might actually use a needle to carefully drain off some of that excess fluid.
At the end of the day, the definitive cure is delivery, but the exact timing completely depends on the condition. For polyhydramnios, too much fluid, we're usually aiming for a planned delivery around 39 weeks. But for oligohydramnios, too little fluid, where the baby is dangerously restricted, doctors typically recommend delivering earlier, usually in that 36 to 37-week window, to keep the baby safe.
Knowing that these complications, while definitely scary, are highly manageable with modern care, it leaves us with one really provocative thought. As our medical technology gets better and better, how much closer are we to finally solving that 50% of excess fluid cases that still remain a complete medical mystery?
Thank you so much for joining us for this explainer today. If you found this clinical walkthrough helpful, please do us a huge favor. Like, share, and subscribe to the MediByte channel for more clear, straight-to-the-point medical explainers. We'll see you next time.